Welcome to Pause for the Truth, where you can sit back, relax, and hear an honest dialogue about health, wealth, legal, and social issues. The hosts are Dr. Rogers Kane, family practice physician, and Jocelyn Turner, health education consultant, with co hosts from the Northeast Florida Medical Society and its foundation. Stay tuned for the truth about matters affecting you and your family. We're here to tell you what's really going on and why. Good evening and welcome to Pause for the Truth. I am your co host, Jocelyn Turner. I missed you guys last week. I was hanging out in Alaska, Dr. Kane, and I tell you what, I just, I really look forward to our podcast weekly, but I'm super excited to be back this week because we have a special friend of mine who's on and has some good information to share with us about beyond the diagnosis, prostate cancer, genetics, and the power of knowledge. How are you doing this evening, Dr. Kane, before we introduce our special guest?
Well, I finally got cooled off after what since Friday, air conditioning out at the office, air conditioning out at home, and I got at least the one at home fixed today, and we waiting to see what happens with the one at the office. But finally, last night I slept in a sauna.
You know what, Dr. Kane, I had a sunshade up in my car, and I know this sounds, we always have to have a teaching moment, but after having it up all day long, it was still 111 degrees in my car. And I think about the children and pets that people have left in their car, and oh my God, the heat is stifling. So this is just a quick reminder to folks to please do not leave a window cracked for your pet. Do not leave your babies or your children or elderly adults, people who have illnesses. No human being, person, whatever, pet should be left in a hot car now. Please, please, please check the back seat of your car and make sure you did not forget to leave your loved ones in the car. It's just unbearably hot.
Oh yeah,
Um,
it's miserable. It is miserable, and I'm happy to say, and even with the heat that I experience, it's nothing compared to the heat that others who don't have uh, the wherewithal or the ability to pay somebody to fix their air or even have air conditioning.
right.
So I don't complain. You just go ahead and you deal with it. But I do want to make sure that add to what you're saying is that people check on their neighbors. You
Yeah.
know, a lot of these elderly people don't have that temperature sense that
Hmm.
help gauge,
Hmm.
can help gauge their hydration level and their uh, heat stroke level, yada yada yada. So please check on that elderly neighbor, male, female, doesn't make a difference. Check on them and just make sure they're comfortable. If they're not, try to find a way to make it happen. We'll help out if that be the case, some kind of way. We'll find some way to make it happen.
So true, Dr. Kane, as you said, and I know you said you always talk about your geriatric patient population. So I know you're going to give a shout out to them as well. And you're right. In addition to your loved ones, also your elderly neighbors. And most of us know who our elderly neighbors are.
Yep,
And we certainly don't they might get confused about the thermostat, adjusting the thermostats,
exactly.
in terms of sometimes they get cooler at night, so they'll increase the thermostat and forget to turn it back down during the day.
Don't worry
So,
about the electricity bill. You
right,
know, yeah, it's like
yeah,
don't worry about that. We can see if we can help the city somehow find out a way to help these people out.
exactly, exactly. So, our behind the scenes guy, I love it when he pops in because he obviously has something to say tonight, or as he always says, he just wants to have the balance on the screen.
Absolutely. Absolutely. I'm just here for screen balance.
But tilt
How
it
you
to the
do-
other side.
how you doing this
Turn
evening,
it around.
Tyrone?
I am doing well. I am doing well. Thank you very much. Dr. Kane, sleep on ice until you get it cool. Okay.
I did.
So enough banter. Let's get
Yes.
to tonight's discussion. So I am pleased to introduce to you all Dr. Iwan Cobran. Dr. Cobran is a research scientist. I hope I can say that about him. That's what I think of him anyway.
Yes.
With Mayo Clinic Cancer Control Center, and he's located all the way in Phoenix, Arizona, but he works globally in the work that he's doing with prostate cancer. And I say that because he was, I remember last year, and it might have been around this time, Dr. Cobran, when you told me you had just gotten back from Africa or was going to Africa. So that's why I say your work globally with prostate cancer. So welcome to Pause for the Truth. How are you doing this evening?
I'm doing well. Thank you, Jocelyn, and thank you, Dr. Kane. As you guys talked about the heat, it's about 120 degrees Fahrenheit in Phoenix. That's the temperature. And so one of the things that I often think about, so you both mentioned families and children and dogs in the car, but think about the unhoused, people who don't have homes.
Yeah,
and so
Exactly.
in Phoenix, there's cooling centers that allows people to kind of get out of the heat, but it's crazy. Like 5 minutes outside, and I'm like, boy, that 120 degrees, or and then it feels hotter in the car, so it's hot. So absolutely, I completely agree. Yeah.
When I went to, thank you for saying that. When I went to Phoenix the first time a couple of years ago, because I've been working with Dr. Cobran on a prostate cancer project, and I remember one of the Uber drivers said that lawn guys or roofers rather, they start their work at 2 and 3 o'clock in the morning to avoid the heat. And just think about that. When they said that, I was just like, wow, we don't think about the adjustments. And so that's why, Dr. Cobran, we've had discussions in the past on our podcast about climate change, and we really hope that people take it serious, because people have to know that these temperatures are unbearable. And I mentioned I was in Alaska last week. I was in South Alaska, but it was in the 60s, and Alaskans were not used to that.
The 60s.
Right? Yeah, you know what I mean? Even though it's their summer, but still it was unseasonably warm in Alaska. So we have to know that this is serious, but we also have to know there's something we can do about it. And if you don't know what to do about it, Google it. Like we Google our favorite restaurant, where to go eat or whatever. Google what can you personally do about a climate change. So anyway, I'm ready to delve into our discussion tonight. Again, for those of you who are just tuning in, we have Dr. Iwan Cobran with Mayo Clinic Cancer Control Center. We're talking about beyond the diagnosis, prostate cancer, genetics, and the power of knowledge. Dr. Cobran, I want to start, and I'm going to call you Iwan because that's what I call you on a regular basis.
Sure.
Can you share your personal or professional journey that led you to focus on prostate cancer and genetic education?
Sure. That's a very good question. And that question is something that motivates me today in terms of as I think about the studies that I want to do and the impact that's going to have. Because for me, it's the impact that's going to have, but it's the legacy of the work, and it's, and so when I think about my grandparents and the legacy, when we think about our ancestors, the ones that came before us, for me, it was my grandfather who, we just had a special bond. My grandfather and I, we had a very special bond, and my grandfather had prostate cancer, and for a very long time. And I'm originally from the islands. I'm originally from Jamaica, so I can turn on my Jamaican accent just like this, as I need to. And so when I'm home with my family in South Florida, or I go back to Jamaica, or I'm visiting, my accent is very strong. But and so those are some of the things that you want to be able to. It's kind of like when, if you're from the South and you've relocated to the West, and then when you go back to the South and you're amongst your family, that Southern accent come out very strong. And then when you go back home, people are like, I didn't know you had a Southern accent. It's the same kind of thing, the same kind of. But my grandfather and I, we had a very special bond. lived in Jamaica his entire life. And my grandmother, she would travel back and forth between Jamaica and the States. And when my grandfather passed away, I was in graduate school at Howard. And my grandfather passed away my second year in graduate school. But we kind of knew that my grandfather wasn't doing so well, and he was diagnosed and he was going through treatment. It was a 10-year journey. But the thing that was surprising to us as a family, about a week after my grandfather was buried, my grandmother was diagnosed with stage 4 breast cancer. And that was a shocker. We literally came back from the funeral, got back to South Florida. Grandma wasn't doing well. Grandma went into the hospital and she was diagnosed with stage 4 breast cancer. We couldn't understand how this could happen. We as a family, there's even times now that I'm just like, I get teared up, I get frustrated because I don't understand how she had access to world-class medicine and fell through the cracks, right? And so to some extent, I was at graduate school. I was in graduate school, and it wasn't the result wasn't that well for my grandmother, because I think 3 or 4 months later she passed away, because at that point the cancer, and she had a very aggressive type of breast cancer, and so at that point the cancer was all over. They basically was just like, there is nothing that we can do for you at this moment. Go and be at peace. And that's me kind of like summing up, right? Her situation. And so reflecting on where I was in graduate school, and I was just like, there must be a reason why some communities are more likely to develop cancer, whether it's prostate cancer, breast cancer. Colon cancer is another huge one in underserved or African American communities. And so for me at the time, I was second year into my program at Howard, and I really wanted to understand cancer survivorship and outcomes. And so based on my lived experience, seeing 2 of my beloved family members passed away so suddenly, specifically my grandmother, my grandfather, we had some time for closure, but I remember taking my comps, or taking some exams at Howard, and I called my grandmother, and she said, I never really got that closure. She said, well, I'm gonna go and do something for a couple of months, and then that was it. Like, that was my last conversation. I was in graduate school and I was taking an exam, and I called my grandmother before walking in, and that was the extent to which that was our final conversation. And so for me, it just really led me into understanding. So I'm a pharmacoepidemiologist, and so it's a big term for just say that I study public health and epidemiology with a pharmacy spin on it, right? And so I'm able to look at large data sets. So the National Cancer Institute has a large cancer registry. Oftentimes I use this cancer registry to understand prostate cancer trends, but you can use it you're not limited to prostate cancer. You can study breast cancer, colon cancer, you name it. So essentially everybody that's diagnosed within the United States it's de-identified data. So for the researchers out there, it's not data that is identifiable. So you wouldn't be able to search my data in it. It's de-identified. You probably just get it's scrubbed from all personal information. But what it does, it gives you a lot of trends. It gives you a lot of what's going on at the national level, and then you can look at you can turn it and look at it from a zip code level and kind of find out what's going on in this zip code. And what it does give you is, from a research standpoint, one of the things that I love doing is community-based participatory research. And so Jocelyn and I, we've been working on a project, prostate cancer genetics project, over the last, I would say, about 2 years now. And that is truly community-based participatory research. What we do is, with that study, we pull together community advisory boards of various different community members. So because Mayo Clinic is 3 locations, we have Rochester, Jacksonville, and Arizona. What we were able to do with this study was to pull together community advisory boards from all 3 of those locations. These are community members who are giving us advice. They're weighing in on the research methodology, on the flyers, on the educational intervention that we're doing from the beginning of the study all the way through. And so those are some of the things that I feel is important. So my personal journey was 2 beloved members of my family succumb to cancer, which means that cancer from a genetic standpoint is in my family.
Yeah.
So I reflected on that, and that kind of drove me to where I am in terms of being able to look through the lens of having been a son or a grandson, and to be able to understand cancer from that it's not just a number. When you look in these large registries, you just see numbers. You see 25,000 people, or you see 100,000 people, and you're like, okay, that's numbers. But each of those numbers, each of that 25,000 people or 25 million people, they're individuals, their family, their mothers, their fathers, their sons, their grandmothers. There's aunties, their Auntie Lulu, there's Auntie Shanae. There's all different kind of people associated, and so you can't just be so. One of my mentors, when I started doing cancer registry stuff, he really impressed upon me that it's not a number. These are individuals and these are family. And so please take it personal. And so I do.
Yeah. When you think about, and, since we've been doing the work, the one thing that I learned, I remember when my dad got his prostate cancer diagnosis and I was taking him to treatment, you try to stay lively with folks, right? Not be morbid. Fortunately, he didn't die from prostate cancer, but rather lung cancer. But when I remember telling him when he was diagnosed, I said, "Well, Dad, I don't have to worry about getting prostate cancer because as a woman, I don't have a prostate. But I recently learned that because of genetics and my dad's prostate cancer diagnosis, I'm at risk of breast cancer." And so it is very important that we have a serious conversation. And on that note, that we have a conversation with our family members. And by the way, I text one of my friends about tonight's show, and they said that they got genetic testing. Great. And it tested negative, even though his father had prostate and liver cancer. But his genetic test tested negative, and he was surprised. So when we talk about, though, Dr. Ewan, beyond the diagnosis, for me, beyond the diagnosis might mean something that is for you. But for me, beyond the diagnosis is the impact that a cancer diagnosis has on the family.
Yeah.
It doesn't just affect the individual, but beyond the diagnosis to me is also that the person who's diagnosed could be the principal breadwinner in a home, right? And so when that individual is diagnosed, going through treatment, they may not be able to work. We can't make an assumption that they have insurance, that they get paid time off. And so a cancer diagnosis means so much. That's why I love being educated by you about genetic testing. So what does beyond the diagnosis mean to you in the context of prostate cancer?
Jocelyn, that's a great question. It means, similar to what you've mentioned, it means that it's not just an individual diagnosis. It's there's ramifications for the entire family because we are a part of community. We're communal people, right? We can't live isolated, right? That's one of the things that I've learned in my life, that you need community. And so when you're diagnosed, it's shocking for the individual. It's life altering for the individual, but that at the same time, it's that family that comes alongside you that is taking you to chemotherapy, that is taking you to your radiation oncologist. And so beyond the diagnosis is truly, and that's why I love the topic of this podcast, of this show, is that we, there are times that we'll do community research and you'll hear from the respondents, we'll do focus groups, and they'll say, when I got diagnosed, it was kind of like I was a deer in the headlights, but then my family came around me and they really helped me to kind of, even at my lowest moment when my spirits were low, I had the sense that I was going to be okay because my family support system was so strong, right? And so beyond the diagnosis truly means that, we have to go beyond the diagnosis, because their genetics, as it relates to beyond the diagnosis, it plays a role in that it can create some illumination. So there's two types of genetics, right? There is germline, which looks at the family history of cancer. And so your friend Jocelyn that said that his dad had, I believe, lung cancer and prostate cancer.
Liver and prostate.
Liver. Okay. Okay, great. So it means that so when they did his genetic assessment, so we know that we get genetics from, or chromosomes, I'll just say this: we get DNA from both our parents, right? So there's your mom and your dad. So what it could mean, not gonna make projection. What it could mean is that the genes that, like, say for example, if dad had BRCA2, which has been shown to be a lot more aggressive in terms of prostate cancer for men, it means that maybe he didn't inherit some of those more aggressive cancer genes from his dad, right? So maybe what would have happened was he was favored, or I'll say it like that, and inherited certain genes from his mother. And so remember now, when like the birds and the bees, mom and dad come together, genes are being passed down, right? And that's the best way for me to put it. And so beyond the diagnosis means that you can look at the germline, which is the family tree or the family history and do a genetic assessment on every single person in the family tree, going back to as far as you can. That's germline. Somatic genetic testing is more so at the cancer level. So after you've been diagnosed, you can take a look at the tumor. You can get the tumor genetically profiled, and then by getting the tumor genetically profiled, that with the tumor, you can use that information to determine course of action in terms of treatment wise. And so there's that. So the somatic level is more so at the tumor level, and then the germline is more at the family history level. And so that's the difference. Okay.
Well, Dr. Kane, I don't want to ask Dr. Cobrand all the questions. You silent, look like you're pondering. What's going on in that brilliant mind of yours?
It's not so brilliant today, and this is one of those times that I'm sitting back trying to learn. I do appreciate the understanding of the genetic and the the germline versus the genetic. Not germline versus
somatic. Yep.
The somatic approach to things, and just sometimes for our audience, we how we try to break it down to simple logic, simple like me, in which if genetically wise you may not inherit anything from your parents, as just opposed to them being passed on these cancer genes to you. But then you turn around and you just have a cancer that may not be related to your parents, okay, or other loved ones, but you still got to deal with that cancer. And we may take the approach of identifying certain markers, I call them markers, within those cancers, and that will help along with the treatment as to whether or not we there are certain drugs. Well, I'm not going to get into the technicality, but anything from the PARP inhibitors and stuff of that nature that you can use to help treat those individuals and be more effective at treating them, rather than just doing the old style treatment of where we throw out chemotherapy drugs and all kinds of side effects occur with them. And you have to get it to a certain dose level for them to be effective. And now we got these, because of the genetic testing and the genetic understanding, we got additional medications that we can add, and it won't make the treatment so toxic like we knew about in the past. So if you tell somebody chemotherapy, first thing they think about is bald head, which mine is just naturally occurring. It ain't because I had chemo. But first thing they think about is bald head and loss of hair and stuff of that nature. But these days, it's a lot more. We got a lot more aggressive therapy without having the aggressive side effects that we knew about in the past. That's all I can offer to.
Well, one of the things one of the things I like for us to step back when I look at this here and I think about it is, first of all, what is a prostate? What is the prostate's function? And if it leads to these great challenges and it has no function, why can't we just remove it and therefore not be saddled with the challenges of prostate cancer?
Well, to be honest with you, I'll go ahead and address that somewhat from when I talk to my patients. Prostate does have a function. You know, you can't say the prostate doesn't have a function. Prostate has a function. If I had to just narrow it down to one specific function that it has, it adds volume to your ejaculate. Because if you just looked at the amount of sperm and not have these prostatic secretions that come along with the sperm, you might have a very little small amount, a couple of drops of sperm, and that might not hit the target where you need to be able to impregnate, you know, wife, spouse, whomever. May not be able to impregnate them. Prostate puts enough fluid in there to make it sperm friendly, so the sperm can travel to the egg once, you know, you ejaculate. So it gives it a lot more volume. All right, which is probably one of the reasons that we tend to see a lot of cancer sometimes. So some people may be using a little bit too much volume in their younger days for one reason or another. But yeah, it has a purpose. So don't think it does not have a purpose, especially in your younger days. And that's why we not as concerned, even though it does occur, not as concerned about prostate cancer in your much younger days. All right. I'm going to say before 40 these days, before 40. It doesn't say that it doesn't occur before 40, but we don't have that level of concern like we do when we get to 45 and 50 and beyond for prostate cancer. And there's a higher incident. I tend to note a higher incident in the early age in Black males more so than our Caucasian counterparts.
Yeah, I know when my dad had got his prostate cancer diagnosis, being a health educator, I talked to and the oncologist told my dad, you know, asked him, did he have any sons? And to make sure that he has a conversation with his sons. Ewan, I want to talk a little bit about genetic testing. What does that actually involve? And when should someone consider it?
Okay. So genetic testing just involves analyzing a person's DNA, typically from blood or saliva, to identify mutation that can increase the person's risk for prostate cancer. So that's essentially what genetic testing is. It's analyzing the DNA, usually from blood or saliva sample, to kind of determine what are the risks, what are the levels of risk for the person. And so there's two types. As I mentioned earlier, there's germline testing, which looks at inherited mutation, so things that you got from mom and dad. And then there is somatic that looks at DNA from the prostate tumor. And so that's the two types of prostate cancer genetic testing. And so when you just break it down simply, with genetic testing, we want to know what kind of mutations we inherited that is putting us at risk for prostate cancer. And then at the tumor level or somatic level, we want to know what's the DNA of the tumor. That's basically, and tumor is the cancer cells or the cancer. That's what it is.
And we're mainly looking at treatment when we looking, I mean, the ability for certain prescribed treatment when you're looking at it from the tumor level. But if we look at it from the genetic testing from a family level, it kind of puts good primary care docs, put them on alert that you have a much higher risk for developing prostate cancer. And so I'm being more aggressive at monitoring you more so than somebody else. I'm not saying I don't be aggressive in monitoring anybody, but I am definitely aggressive at monitoring those individuals who have a proven line, a genetic line of prostate cancer. I need to go all out and make sure they understand and stay on top of them, that we get these testing done, and for them not to be slacking off thinking that well, that happened to my dad, but it won't happen to me. That's what us black men, we tend to do that. We think they have that very omnipotence that we don't tend to go do the things we need to do. So it allows me to be more aggressive in terms of monitoring that patient.
Thank you, Dr. Kane. If you're just tuning in, we're talking to Dr. Iwan Cobran. We're discussing beyond the diagnosis when prostate cancer genetics and the power of knowledge. And by the way, if you did not know, June is Men's Health Month. If you don't ever remember anything, know that the month that is Father's Day, Men's Health Awareness is recognized. The month that is Mother's Day, Women's Health Awareness is recognized. Talk to the men in your life, your husband, your significant other, your father, grandfather, uncle, brother, cousins, male friends. Encourage them to go in for those very important health screenings, not just their blood pressure, cholesterol, blood sugar, glucose. Those are also important, but also if they're at an appropriate age, look at their prostate specific antigen, also known as PSA. And I say to all of you, since I've been doing work with Men's Health for over 20 years now, you guys just get so squirmish when somebody mentioned a digital rectal exam. I don't understand why, because as a female, we know about the pap smear. So we've been doing it for years and years and years. But oh my goodness, when we mentioned the DRE to you all, you just go all haywire. So, but on a serious note, talk to the man in your life about getting those important exams. Iwan, I want to ask you, are there specific genes, and you kind of touched on it, but are there specific gene mutations linked to aggressive prostate cancer in men? You talked about the BRCA or BRCA, I don't know which way you pronounce it, 1 or 2 or what have you. Can you talk a little bit about that?
Sure. So BRCA2 in particular is strongly associated with aggressive prostate cancer. So these are the more germline. So once again, remember we talked about germline and we talked about somatic. So germline is when we looked at the family history, right? So or inherited. So inherited genes that are passed down from mother to son or mother to or from the family. So BRCA2. So in men is associated with higher prostate, with the likelihood of more aggressive prostate cancer. There is CHEK2 is another gene mutation that is associated. It's moderate in prostate cancer rich, but it's more so the BRCA2 that is particularly associated with more aggressive prostate cancer. That's germline. Then at the tumor level, the somatic, there's this gene called TP53. It's commonly associated with aggressive prostate cancer or aggressive and treatment-resistant prostate cancer. And so those are some of the genes that are at the tumor level, and then at the genetic or germline level that is more likely. So Jocelyn, remember you mentioned at the beginning of the show that you didn't have to worry about prostate cancer because your dad had prostate cancer, but then you discover that you are at risk. So say, for example, if your dad passed on BRCA2 to you, then that is, you can be likely to develop breast cancer if you are a carrier of that gene. So yeah.
So do people typically get genetic testing once they've gotten a cancer diagnosis, or can you go and get a genetic testing at any point, and does insurance pay for it? I know that's a loaded question, but
it's a very loaded question. So you can get germline, which is that family history before and it's more of a more predictive kind of tool in that sense. So say, for example, you want to know your risk for certain cancers, or what can happen is, say, for example, a family member is diagnosed, and this is why the topic of this show is so important, or the topic of this one is so important, beyond the diagnosis. So say, for example, if you're diagnosed and you want to make sure that the next generation of people in your family has options that you did not know, like say, for example, I was diagnosed with liver cancer, and I want to make sure that everybody in the family, and it was never been diagnosed in my family. One of the things with my grandmother, when she was diagnosed with stage 4 breast cancer, there was never anybody else, and she was the oldest, right? But then she had aunties, but there was no one else in her family. In fact, when she was diagnosed, she was just like, cancer doesn't run in my family. She was just like, this doesn't happen. And because she had not known, but not only that, but in her, and so in her situation, if she wanted to make sure that everybody else in the family knew their risk for developing cancer, various types, then she could elect to do germline at diagnosis, right? But then and somatic. So she can elect to do germline at diagnosis, and then she can also do somatic because she wants to analyze the cancer tumor. So she can do somatic. Now, if you don't have any kind of cancer diagnosis and you want to know, you want to know from the germline standpoint in terms of what did you inherit. You can get germline testing. You are going to pay. Your insurance may cover some of it, but at the same time, you will have to pay something out of pocket. But for a lot of people, paying that out of pocket to kind of have a forecast of what I may be at risk for, it's a trade-off, right? But then at the time of diagnosis, most insurance cover, Medicare does, most insurance cover somatic genetic testing because it's such a powerful tool. Dr. Kane mentioned that, back in the day, they would just, the chemotherapy wasn't so targeted. We are now in the era of precision medicine. It's now wherein we are very precise with how we're treating patients, or from a researcher, what I've seen from a research standpoint is that we're using personalized medicine and precision oncology to really target the specific tumor. And so I think that plays a role. The other thing why genetics is such a big game changer is that it kind of, say for example, there are certain drugs that are in clinical trials, and there are options that you can use. So say for example, the treatment course that you're using is not working for you, but you want to know, am I eligible for any other clinical trials that are out there? And clinical trials are drugs that are being developed. The other thing that's key, people of color are less likely to participate in clinical trials. And so, that's something that we have to talk about as well, because, if clinical trials are where you're having innovative medicine come into market or getting ready to come out, but then certain communities are not participating, are not participating in those studies, then how do we know that it works in certain communities, right? And so those are some things that we have to think about as well. And so that's why genetics is so important, because at the diagnosis phase, it can help inform your treatment, and at the same time, it can kind of let you know what in terms of clinical trials am I eligible for. And at the germline level, it can just be a forecast. Like it can be something that helps forecast, I'm going to be at risk for this. I'm going to be at risk for that because it runs in my family. And so it just helps you get a better understanding of what you may be at risk for. So
yeah, the only thing about it though, I think about if someone gets genetic testing and they're shown to be at risk, then they're like, okay, what do I do now? Right? Obviously, the things that we do, there are certain things that we can do, certain foods that we should eat and avoid that will help reduce our risk, maintain a healthy weight. So many things. There are things we can do something about, but what we cannot do about is our family history. We can't, mom and dad has already been chosen for us, right? And so that's why it's so important as we have this conversation to let people know there are things that we can do to lower our risk. Dr. Cabran, I'm going to take a break now. Tyrone, each week we feature what we call a pause for the truth moment. That's not what we call it, but I can't remember what Tyrone, the technology guru, named it. But this will be an opportunity for you. Don't go anywhere, Dr. Cabran. Don't go anywhere to our audience. We're going to take a little pause moment. Tyrone, take it away.
All right, fellas, gather around because I'm about to hit y'all with some real talk on prostate cancer specifically for us, black men and minorities. There's a lot folks don't tell us, and I'm here to break it down with 10 things you need to know. Let's get into it. Number 1, prostate cancer hits black men harder. We're not just more likely to get it, but we're twice as likely to die from it than white men. That's not to scare you, it's to wake us up. Number 2, it can sneak up with 0 symptoms. Most guys feel fine until suddenly they don't. That's why regular checkups matter, even if you feel like Superman. 3, age is a factor, but not the whole story. Sure, risk goes up after 50, but for us, the clock can start ticking earlier. Ask your doc about screening by 40 or 45, especially if you've got family history. 4. Speaking of family, if your dad, brother, or uncle had prostate cancer, your risk is double. Don't brush that off. Bring it up at your next checkup. 5. There's a myth that prostate exams are painful or embarrassing. Look, it's over in seconds, and it could save your life. Real talk. Being shy is riskier than being proactive. 6. Diet and exercise play a bigger role than you think. More veggies, less red meat, and moving your body can lower your risk. It's not just about looking good for the gram, it's about staying alive. 7. Not every prostate cancer needs to be treated the same way. Some grow fast, others slow. Don't panic. Get the facts, then decide with your doctor what's best for you. 8. PSA blood tests aren't perfect, but they're an important tool. If your numbers are high, don't freak out. Just means you and your doc need to look closer. 9. Treatment side effects are real, like changes in sex drive or bathroom habits, but there's help. Don't suffer in silence, and don't be afraid to ask questions. And 10, you're not alone. There are whole squads of black men sharing their stories, encouraging each other and breaking the silence. Reach out, talk about it, and look out for each other. Listen, prostate cancer isn't just an old man's disease, it's our issue too. The more we know, the better we do. So check up, speak up, and take care of yourself. That's real strength. If you learned something, share this with your brothers because knowledge is power. Stay healthy, kings.
I love that, Tyrone.
I
That
just
was
want to
wonderful.
clarify one thing on it to make sure people understand. Just because your PSA within normal range does not mean you don't have prostate cancer. You need to take everything into view to make a determination. Sometimes the PSA may be below that quoted unquote the quoted value of 4, okay, but a lot of times it's the rate of rise of that PSA that might be your first sign, a signal that prostate cancer could potentially be an issue for you. If 1 year you're 1, and then all of a sudden the next year you're up to 3, that's a 3 times, that's a significant rise in your PSA. So don't just think because your PSA was in that normal range that you're not likely to have prostate cancer. Let your physician explain that to you. Discuss it with him or her as to what your value may mean.
Yeah, that's exactly what happened with my dad. He had a normal prostate PSA test, but when he went back, because he was going regularly, when he went back the next year, it was slightly elevated, but it prompted them to do the test, and that's when it was discovered that he had prostate cancer. But the good news, because his cancer was diagnosed early, then his treatment option was good. His prognosis was good, and therefore he did survive it. But unfortunately, as I said, he succumbed to lung cancer because he was a smoker for over 30 years.
And that was many years ago, JT. I just want to make sure your audience go along with your story, because I knew your dad, obviously. But that was many years ago. We got so many more weapons in our armamentarium these days that it doesn't make any sense for men to be dying from prostate cancer without. I'm not going to say no one will die from it, but it doesn't make a lot of sense that all of a sudden you got prostate cancer and you had not been being checked on a regular basis for it, and having whatever your PSA values were and how they presented, being evaluated by someone from a critical standpoint. As you know, we always talk about Dr. Christopher Williams, and Christopher Williams is great at making sure that he does understand even the slightest little rise. He say, look, your PSA normal, but I think you got prostate cancer due to genetic testing that I have ran on you, or I want to run some genetic testing on you. So make sure you listen to your loved ones in your primary care, but especially your urologist.
Yeah, and I know that Dr. Kane, several of our audience members are physicians, but in general, though, Ewan, how can people better communicate the value not just physicians, but the community in general, or loved ones in general, communicate the value of genetic testing in our communities, particularly in underserved communities. And again, when people are juggling whether or not having money to buy food versus medication or taking care of their medical care, sometimes they're just not able to make that decision. But I always tell people to check with your insurance to know what it will cover. Don't assume that it won't, and don't assume that it is a cost for you. But there are numerous people who are on in our listening audience who might be able to afford it. How do you convince them to get genetic testing to know their risk?
Right. So, and then often, Justin, you're absolutely right. Often some of these companies they have these discount programs wherein it drastically reduced the cost associated with, drastically reduce the cost associated with the tests. And so the importance of genetic testing, especially you're diagnosed and you want to understand, am I that BRCA2 person for prostate? Let's say we're talking about prostate cancer.
Mhm.
Do you want to know, am I? So that the reason why prostate cancer genetics is such an important thing, some men will develop prostate cancer and it may be a slow growing prostate cancer. For that man, his likelihood of I'm not going to make forecasting, right? But at the same time, there's some people that develop prostate cancer, and it's an aggressive type. The genetics play a role here because it can illuminate which kind of treatment options are available for you. And so, when I say if we're in the era of precision medicine and there's a toolbox, right? And the genetics can help you by identifying, do I need a screwdriver? Do I need an Allen wrench? Do I need this? How do I need to, how do I need to attack this? And so I think that's the approach. The approach isn't, well, I'm just going to throw the whole toolbox at it. We need to be, you need the right tool for the right job. Like your plumber, if your plumber shows up at your house and he brings electrical equipment, wrong plumber, right? Right? That is not the person. That's not the person. And it's the same kind of approach that we have to use here, because we need targeted therapy, precise therapy, so that it gives me a better treatment outcomes. And then for most men, the key thing that we think about is, am I gonna get back to my sexual activities after treatment? And so why not think about if there are treatment options that are going to help you preserve those sexual activities or preserve the nerves on both sides, then why not of the prostate? Then why not think about those treatment options? And so that's why I think it's important.
Well, one of the things I try to make sure these guys understand that if the earlier the detection, it might be less likely that you're going to have surgery, which can then cause, erectile dysfunction. Let's put it out there on the table, because that's what some of these guys worry about, more about erectile dysfunction than they do get treated for the prostate cancer. So, but the earlier you're diagnosed with it, which means the more aggressive you are with being screened, okay, then the less likely you're going to need the surgery, and so on and so on. Let me point out one thing. Ken Jones was alluded on the fact that, insurance usually doesn't pay for prophylactic intervention, meaning they don't usually pay for prevention of prostate cancer with genetic testing, but they do for breast cancer. And, sometimes though, it depends on your urologist, because, my guy, Dr. Williams is very aggressive with getting them to pay for it. So, just keep that in mind.
Yeah, and it's important to have a good medical team. And if you don't have a primary care physician, get yourself a primary care physician, no matter where you are in your medical care. If you haven't gone to the doctor for years, let tomorrow be a new day and make the call. If you don't know who to go to, look up Dr. Rogers Kane, a local primary care physician, or if you're not local, look up primary care physicians, check with the National Medical Association. If you're in Florida, the Florida Medical Association. If you are an African American, and some people prefer to go to someone who looks like them, Dr. Cobran. It
Florida
doesn't
State
mean that
Medical
other
Association.
it,
Florida State Medical
Florida
Association.
State Medical Association, but check it out. So, what are some of the key lifestyle or screening recommendations you share with men, Ewan, who are at higher risk for cancer?
So I'm gonna let the family physician answer that question first, because that's his from the research side of things. I look at the recommendations as it relates to design and research studies, but at the same time, that's Dr. Kane, what do you think?
Yeah, it's going to go against what most of the people guys listening, especially when it comes out to fatty foods. These fatty foods can increase anybody's risk for any kind of cancer, actually, including breast cancer and prostate cancer. Um, that is not my area of expertise. That's why one of the reasons I always got Dr. Williams and speak highly of him. But I'm especially cognizant of vitamin D levels and making sure that they're appropriate, as well as I'm mainly doing the screening is what I'm really aggressive in.
Yeah, I was just about to say that too, Dr. Kane. I'm sorry for putting you all on the spot, but
No.
I always tell people just make sure you're getting those screening exams, the annual PSA exam, the digital rectal exam. Is not going to last an hour. It's not going to last 10 minutes. It's only a few seconds, but it could save or add years to your life. And by the way, as a health educator for years, almost 4 decades, I've always talked to people about the importance of, and we've had a registered dietitian on who says it every week. And it's a struggle for me as well. And I tell people that oftentimes it's due to culturally what we are accustomed to eating. But we know that I like what Linda Brown is a registered dietitian we've had on, and she said, anything that what should you eat? The things that don't come with a label. And what are those? Fruits and vegetables, right? They don't come with labels if you eat them in their natural form. And we used to joke when I was at the health department, we used to, some of us to have conversations, and we try to get on folks' level, right? So anybody that had a mom or dad, you shouldn't eat them, right? And that is an animal. So if animals come, they had to have a mom or dad, so you shouldn't eat an animal. The point is, we were joking, you need to eat more of a plant-based diet, fruits, vegetables. Yep. And if you're going to eat meat, then it is the way that we prepare the foods, obviously, is important. So I do want to ask
one of the last thing I didn't think about it when you mentioned, but I think watch the vitamin D level, but really watch the dietary intake of calcium. For those guys who get old and still drink milk, Tyrone, you got to be careful of that that milk intake. And like what Jocelyn says, a lot of fruits, green vegetables, but definitely stay away from the high fatty foods.
Moo.
So Ewan, I know you do a lot of work with genetic testing, and have you been a part of conversations though about policy changes that need to occur to make genetic testing more readily available? I know you attend meetings and we talk about, and I know unfortunately, federal resources are not as readily available as they used to because of some of the federal cutbacks. But have you heard any discussions about those policy changes that make, going, like you can go get your blood pressure checked almost everywhere, right, that one day we'll have genetic testing just as readily available? But to go the next step, once you find out you're at risk, what now?
Right. So I have not been at the level where, so I've gone to several meetings, and there are conversations around genetic testing. What I can tell you is that I have seen, and it's more so the tumor base. So at the point of diagnosis, over the course of the last 10 years, it was something that was not covered by insurance, or it was not covered by Medicare. And then here we are 10 years later, and it's something that is being covered, and it's the tumor-based one. So as you're at the point of diagnosis, so there must have been a conversation held at the policy level to say, okay, we need to make this, and it's now standard of care, right? And so there must have been a conversation at the federal level to make it standard of care. And so in the future, we may be having more conversations as we want to look at precision medicine, or there's this field called cancer interception. That's another huge field that is developing full speed ahead, and it's really intercepting cancer before it even becomes cancer.
Mm-hmm.
And so I think in that realm, the germline genetics is going to be key for intercepting cancer in terms of cancer interception. And so I think along those lines, there are going to be policy conversations about, making genetics more at the germline level, more relatively available. And so those are some of the things that we're going to be there.
Yeah.
Well,
so Tyrone, I don't know if this is a pause for the truth moment where you put the drink plenty of water and
yes,
drink more
water,
vegetables and all that stuff.
That
But
was
we'll make that information available on our website. But where do you see the future? And you talked a little bit about it, but where do you see the future of genetic testing and precision medicine in prostate cancer? And again, working at Mayo Clinic with cancer in the Cancer Control Center, I know you are around people who are looking at other cancers in addition to prostate cancer. But what are you seeing as far as genetic testing and precision medicine in prostate and other cancers?
So I think I'll stick specifically to prostate cancer, and I think for the most part, it's that precision medicine, targeted therapy, intercepting cancer before it even becomes something that presents. I think that's where we're going to, move in the needle, that much more further. But in order to move the needle, you have to, that early detection, you can't be afraid. Don't suffer in silence. And I'm also an advocate because of my grandparents. I'm a cancer advocate because of my grandparents, and don't suffer in silence. And so I think that along the lines, I don't want to get too biblical, but my people fear because of lack of knowledge, like those kind of things. We have to get, if you're afraid of don't be afraid to get them the knowledge and the information that you need to make the proper decision. And my big thing is I'm a big shared decision making person. So I love when the patient and the family and the caregivers can come together with the physician and make a shared decision, because it's a journey.
I did that with my dad.
It's a journey. You're going to be going through these treatment options. It's a journey. And so shared decision is going to be a key thing. So, and then I would say clinical trials, enrollment in clinical trials. Don't be afraid. And your participation in these clinical trials is voluntary. You can disenroll at any time. You don't have to see if for example, you join a clinical trial and you're like, at the beginning, I thought that this was something I wanted to do, but I don't want to do it anymore. Then you don't have to. You can say, okay, thank you very much. I think that I've contributed what I can, but at this point, I want to discontinue. And so I think along the lines it's the access to these rapidly developing fast developing treatments through accessing of clinical trials. I think those are things that are going to be important.
That's a good point, because I tell people, many of us are accustomed to taking Tylenol and Bayer aspirin or other medications on a regular basis. And we have to know that people participating in clinical trials, that those normal medications, those routine medicines that we take every day, or the toothpaste that we use, or the deodorant that we use, those were product tested. And those researchers or scientists or developers found out that they were safe for human consumption as we know it, right? And so to participate in clinical trials means so much. We know, unfortunately, about the Tuskegee study, but things have evolved and there are things in place to help protect us from those things. This has been a very interesting discussion. And I think the one thing I think about is if someone is listening and they've had a cancer diagnosis, can they talk to their should they talk to their family members and tell them? Because that's the other thing in doing the work with you that I found out is people said that in some communities, for example, the Hispanic culture, they don't always share their medical diagnosis. Some folks didn't find out until their loved one was well into a cancer diagnosis or after they passed that
We
that's
don't
what
either.
they had. Yeah, and in African American population. So if someone though who's watching had a cancer diagnosis, should we encourage them to tell your loved ones and tell them to ask their doctor to talk to them about getting genetic testing because they want to know what their risk, if they are at risk of developing cancer, and if so, if the test reveals that they do have that BRCA2 or whatever the mutation may be, that there are things that they could potentially do. More importantly, going in for routine screenings. What would you say to folks, Ewan?
See, one of the things that they're common. So you have to understand the psyche as well, or I'll say this is the best way for me to put it, because a lot of times in the past, especially in communities of color, when we got a cancer diagnosis, it came with the stigma of God is punishing me, right? Or I got this because I did something wrong. So in that case, if that's the norm in the community, that God is punishing me, I was evil, I did some stuff when I was younger that I had no business doing, and now here I am 50, 60, 75, I was too loose or whatever. Like that's the best way for me to. And so you have to be able to understand that God's not punishing you for why you got cancer. There's mutations that you inherited, or there's some environmental stuff that would have put you at risk for developing certain kind of cancer. And so, once you're able to understand that it's not a punishment from God or from the higher being, then I think you're able to move past, once you're able to absorb the shock. Some people are diagnosed and they're not ready to have the conversation with the entire family, right? And so I think that you have to take it a step at a time. Like, you might be ready 3 months from now, but right now your life has just changed. You had a life-altering diagnosis, and you may not be ready. You may only want to share that diagnosis with a couple of close family members, and then you get to the stage where you're like, okay, I want to have more. I'm an advocate. This is happening to me in my body, and these are some of the things that I'm going through. And so sometimes a step before even revealing to the whole family is you may decide to be a part of a work group or a peer group of other survivors or other people who are going. And I use the term survivors because day one diagnosis, you're a survivor, right? And that's how I, and so and that's just loosely defining the word survivor, right? And so you may find yourself that being a part of a peer group or a peer networking group of people who are newly diagnosed, and they're talking about or support group. One of the things that our community partners in Rochester, they host a monthly prostate cancer support group for men who are diagnosed, men and their families. The spouse comes, the caregiver comes, and a lot of times it becomes this place of rich dialogue because people are like, okay, are you having this side effect? Are you having this kind of issue as well? And so they're able to have these kind of conversations amongst. And so so the, you have to be able to share what you're comfortable with, and you have to be able to gauge people's comfort level. And so I
Mm-hmm.
think along those lines, I think that's important. So what you're comfortable with, your comfort level, but then at the same time, there is a benefit to um, sharing that diagnosis once you become comfortable, because you're able to impact several other members in the family. We have a community partner that we work here in Arizona with, and she's actually, she works in a cancer facility where she implements the treatment plans. And she'll say to me, Ewan, there's several times that I'm getting ready to implement a treatment plan, and a brother a brother walks in and he's like, man, I didn't know you had prostate cancer, because within the family, no one is sharing. People aren't sharing, but
Yeah.
then they go to the same treatment facility, and they run into each other, and they're like, and it becomes this thing where they're now they're free from the hostage of being able to have the
Wow.
conversation in the family. And so I think along those lines, yeah, but from a standpoint of HIPAA, no one can disclose your information,
Right.
on,
That's
and
a
so
that's an interesting point. There is a stages of diagnosis. It's the initial shock of it.
yeah.
And folks, during my years of being a volunteer, when you talk about being a cancer advocate, I was a part of the American Cancer Society's Relay for Life for years, and met many survivors. Right, so a cancer diagnosis does not mean that you're going to die. Because, and then, as you've mentioned, with precision medicine and the advances of cancer research, the prognosis is better. My dad's prognosis with prostate cancer was very good. He lived for years after his treatment. He got the radiation seed implant
Mhm.
therapy. And that's when I started learning so much about prostate cancer. And oh my goodness, as a female, I have had more conversations with men about their prostate cancer diagnosis. And I'm not ashamed of it. And I say that I use this as a moment to tell the ladies, have those conversations, not just with your man, your boo, your boyfriend, your spouse, but have that conversation with your brothers, your uncles, your dad, because they may need that extra encouragement to go in for those regular exams. So we're at the end of the hour. We actually passed it. We don't want to keep you.
Oh, wow.
You're on Arizona time. We don't want to
Yes.
keep you past your time. But thank you so much. This has been very good conversations. We appreciate it. We do like to give our guests an opportunity to share their final thoughts regarding tonight's topic. So, what are your final thoughts, Ewan, for our audience about tonight's topic?
Great conversation. Final thoughts. Um, Early prevention, early diagnosis is key, especially in communities that are at higher risk for developing prostate cancer. And genetics don't have to be scary. There is a lot of educational materials. Don't be afraid to reach out for educational content, for educational materials. If you don't know, ask questions. Don't be afraid. You can get second opinions, you can get third opinions. So if you're diagnosed and you're trying to figure out your treatment plan and what to do, you can get second opinions. And most doctors are not afraid of you saying, let me get a second opinion. But don't just fall off the map. Don't do, those are some of the things that I would leave you with. But wonderful conversation. And this is a gem. This is absolutely a gem. Absolutely.
Thank you. Thank you so much. And Tyrone, since you came from behind the scene, you have to have what are your final thoughts regarding tonight's topic?
I would like to start by first saying to Dr. Coran, thank you very much for coming on. Really enjoyed you. Obviously, a wealth of knowledge and information, and that's what we seek to do here at Pause for the Truth. I want to take just a little different approach and kind of go into some of the things. I think it's important for men to engage with other men on this topic. I hear when you say, Ms. Jocelyn, that women, you need to talk to the men in your life. I don't know how effective that is. Women urge the men in your lives to talk to other men. There's a conversation that goes on between two men that is greater urgency and impactful in these kind of situations than goes on most times with women in their life. So my thing for it is men, engage with your friends. You'll be surprised when you bring the subject up, how others get engaged, how others have a frame of reference for what you're saying, and they have an insight that can urge you better into your own treatment. And so engage with your friend men and get that valuable information.
Thank you, Tyrone. And Dr. Kane, in your closing remarks, can you also mention how soon a man should start getting a PSA exam or PSA test, I'm sorry, and a digital rectal exam? And does it matter if they have a family history of prostate cancer that they should start getting those important screenings just in case we have, like for example, with my father's diagnosis, I have nephews and brothers. So can you chat a little bit about that in your closing remarks?
All right. So again, I want to also thank Dr. Cobrand for coming on to our podcast and enlightening us on genetic testing. We did, I did post some as far as dietary prevention for or help in prevention of prostate cancer. That's going to be posted on our website. But as far as yours truly, what I do is I'm very aggressive when it comes down to African American males. I start my PSA at 40 easily without reservations. Don't usually get that much of a benefit before then, but starting at 40, I also get those guys used to the idea of having a PSA checked annually. Okay, there are certain recommendations about the United States Health Task Force that differ from mine, but I also don't think that they look too much at African Americans in details. I think they use more of a generalized proposal starting at 50, which is crazy from our perspective. I would, with the digital rectal exam, since a lot of guys don't really want to have that done, I may wait to 45 before I do it, but definitely the PSA, I will start that at 40. But that's my own way of practicing medicine. Okay. I can concur with Tyrone to a degree that men are, when they discuss with each other, there's a whole different tone that they may take in terms of listening to another male, but that's some men. Some men need that wife, that loved one to say, look, boy, go out there and get this, go out and get your PSA, get your prostate examined, because I don't want to be a widower, but I'm going to make sure I keep my term life insurance. That's what I tell them to tell their husband. Make sure I keep the term life insurance valid on them so that Joe can get your gal and you be gone if you don't want to take care of things like the way you should be. So you should do. So I think that in all honesty, men talking with men is great. But I think you also need the approach of women talking with men, and whether it's your sister, which they don't usually talk too much, but I have a lot of sisters. I mean, my sisters will talk about it. They encourage me to go look at them. They don't want to be without their brother. The wife, she's adamant about it. And they start talking about erectile dysfunction stuff. Their wife is quick to tell them, like, I don't care anything about that. I want you alive first. And the one thing, and I'm gonna be quiet after this, the one thing I do want people to remember, and that is, just because you feel that you don't that you'll be okay and you don't need to get this kind of testing done aggressively, it's not fair to your loved ones to have to take care of you, wipe your butt, you in a nursing home because you got prostate cancer that's currently not treatable, but was or would have been if you would have gotten checked. It's not fair to them to put that burden on them to have to look over you when you had an opportunity to take care of it yourself. You walk out there and get hit by a Mack truck, that's a whole different ball game. You know, we're willing to jump up and intervene, do what we need to do for our loved one. But when you have an opportunity to do something for yourself and you willingly choose not to do it, that's unfair burden you place on your loved one. So get your ass out there, get your prostate examined, get your blood work done, and call it a day.
Thank you, Dr. Kane. And thank you, Dr. Cobran, for sharing your knowledge. And thank you all for tuning in to today's conversation on prostate cancer, genetics, and the power of knowledge. We've learned that knowing your family history and understanding your genetic risk can be life-saving, but that's only part of the picture. Participation in clinical trials is also critical. It helps advance treatments, ensures diverse communities are represented in research, and brings us one step closer to equity in cancer care. We need more men, especially Black men, to be part of these conversations, these decisions, and these studies. So talk to your doctor, ask about genetic testing, ask about screening, and if you're eligible, consider joining a clinical trial. Your participation could not only save your life, it could help save others. Be sure to follow us for more powerful conversations that educate, uplift, and inspire action. Until next time, stay informed, stay empowered, and stay connected to your health. Tune in next week for Pause for the Truth. Good evening. Stick around, Ewan.
Yes.
We appreciate you spending time with us on Pause for the Truth. Ms. Jocelyn Turner and Dr. Rogers Kane are grateful for your support. Don't forget to like us on Facebook, catch us live on Twitch, and most importantly, subscribe on YouTube. A big shout out to Tyrone Jackson at Call Tyrone IT Services for keeping us connected. Join us every Tuesday at 6:30 p.m. Eastern Standard Time for more enlightening discussions. Thanks, and see you next week.